This presentation is on renal transplant. The objectives include knowledge and understanding of all aspects of renal transplantation and the application of that knowledge for patients in a clinical setting. A kidney transplant is a surgical procedure to place a healthy kidney from a living or deceased donor into a person who has ESRD. The recipient must take immunosuppressive medications for as long as the organ is working properly. Kidney transplantation is by far the best treatment option available for patients with ESRD. However, less than 4% ever receive a transplant. Currently, there are over 93,000 people that need a kidney transplant. Compared to dialysis, transplantation reverses many pathophysiologic changes associated with kidney disease. Also, after the first year, transplantation becomes less expensive than dialysis. There are three types of renal transplants: living donor transplant, paired kidney exchange, and deceased donor transplant. Of the three, the living donor is the most desirable. Kidneys from living donors can sometimes last almost twice as long as kidneys from deceased donors. On average, living kidney donor transplants last 15 to 20 years. How long the kidney will last depends on the many factors, but the most important is how well the patient cares for the kidney. To make a kidney last as long as possible, patients may take medicine every day. There are two types of living donation: directed and non-directed donation. In directed donation, the living donor chooses the specific person they want to give their kidney to. This type of donation usually happens when the donor and the patient are family members or friends. Non-directed donation is when the living donor does not name a specific person who should receive their kidney. The kidney can be given to anyone in need of a kidney who is a match. A non-directed donation is less common than a directed donation. There are three main blood tests that will determine if a patient and a potential donor are a kidney match. They are blood typing, tissue typing, and cross-matching. Blood typing is the first blood test that will determine if the blood types are a compatible match. This test measures blood antibodies that react with different blood groups. If the blood types are compatible, the next test is tissue typing. The Rh factor plus or minus, or positive or negative, of blood does not matter. It must be determined how well the tissue, HLA, type of the patient and the potential donor match. Each person's tissues, except for identical twins, are usually different from everyone else's. It is believed that the better the HLA match, the more successful the transplant will be over a longer period of time. Finally, a serum crossmatch is a blood test the patient and the donor will have multiple times, including right before the transplant surgery. To do the test, cells from the donors are mixed with the patient's serum. If the patient's serum has antibodies against the donor cells, the antibodies will bind the donor cells and be detected using a fluorescent detection method. If these antibodies are at high levels, the donor cells will be destroyed. This is called a positive crossmatch, and it means that the transplant cannot take place. To do so would result in immediate rejection of the transplanted kidney. Other important evaluations are completed on the potential donor, including a nephrology consult to assess the donor kidney, psychological exam to make sure the donor is emotionally prepared for the transplant process, and completion of education on the donation process. Paired kidney donation or paired exchange is an option when a patient has a relative or friend who is willing and able to be a kidney donor, but he or she is not a match for the patient. In a paired exchange, the patient's relative or friend gives a kidney to someone who needs it, and the recipient's relative or friend gives his or her kidney to the patient. That way, each person needing a kidney gets one. Most people who have kidney transplants get their new kidney from a deceased donor. A deceased donor is someone who just died. This person or their family members decided to donate healthy organs at the time of death in order to benefit people who need transplants. No matter how the person died, his or her kidney will only be given to someone if it is healthy. There is certain criteria that is normally followed to determine if a kidney is adequate for transplantation. You can see those on this slide. On average, deceased kidney donor transplants last 10 to 15 years. They must have normal renal function. Marginal means donor organs have been used with the consent of their recipient. Transplantation from a deceased donor usually requires a prolonged waiting period with differences in waiting time depending on age, gender, race, as well as availability of matching blood type. Blood types B and O have the longest wait times. The doctor can schedule the transplant in advance if the patient is receiving a kidney from a living donor. However, if the patient is waiting for a deceased donor, the patient will have to be available to rush to the hospital at a moment's notice when a donor is identified. Many transplant hospitals give their people pagers or cell phones so that they can be reached quickly. Potential donor organs are distributed based on the information from UNOS or United Network for Organ Sharing. When identifying the best potential recipient for an organ criteria such as level of emergency, tissue match, blood type, wait time, organ size, and geographic location are also considered. If there is a perfect HLA match and the blood type, the organ is usually offered to that person first. If there is not a perfect match, local patients are considered first. Only major organs from those patients on life support have the potential for transplantation from deceased donors. Once brain death is determined and confirmed by 2 attending physicians, management of the donor is assumed by the organ bank personnel. The patient's hemodynamic status must be maintained within very specific parameters to ensure that the donor organs remain viable. When recipients are determined, the donor is taken to the OR for harvesting of the organs. Most organs are harvested by specific surgeons, not necessarily the transplanting surgeon. Meanwhile, the recipient is at the transplant center being prepared for surgery. The surgery is tentative up until the actual time the transplant surgeon visualizes the organ. Cold ischemic time is the time that elapses between cessation of blood flow until the time of anastomosis and perfusion is restored. Maximum transplantation time for any major organ is up to 72 hours. Kidneys are viable up to 72 hours. On arrival at the transplanting hospital, bloods are collected with a request for the laboratory to process this urgently. In addition, a chest, radiograph, and ECG are performed. Next, a medical history and examination should be done with the patient. The presence of potential new medical comorbidities should prompt review of suitability for and safety of proceeding with transplantation. The development of ischemic heart disease, vascular disease, malignancy, or active infection would prohibit proceeding with transplantation. The patient should also be evaluated for signs or symptoms of fluid overload with assessment of patient's weight in relation to their recent clinic weights or current target weight if on dialysis. The patient's usual daily urine volume should also be assessed and documented. A decision also must be made of whether a patient requires dialysis prior to transplantation. Significant hyperkalemia, such as a serum protein concentration greater than 5.5, or fluid overload, should prompt urgent dialysis prior to transplantation. In general, it is better to control fluid and electrolyte abnormalities effectively with dialysis preoperatively rather than to attempt dialysis in a less stable patient post-surgery. Due to tissue damage and intraoperative bleeding, hyperkalemia may worsen post-operatively. If hemodialysis is required prior to transplantation, patients are usually left above their target weight with the aim of avoiding intraoperative hypotension. Minimal or no heparin should be administered during dialysis to minimize the risk of perioperative hemorrhage. After the decision has been made to proceed with a transplant, an immunosuppression regimen is selected. This regimen is usually initiated before the recipient goes to the operating room so that immune function is reduced prior to donor antigen exposure. The choice of immunosuppressive regimen is individualized depending on the circumstances of the recipient. During kidney transplant surgery, the donor kidney is placed in the lower abdomen as seen on this slide. Blood vessels of the new kidney are attached to the blood vessels in the lower part of the abdomen. The new kidney's ureter is connected to the recipient's bladder. The surgery often takes 3 hours, but can last as long as 5. The old kidneys will be left unless they are causing problems for the patient. Hospital recovery for a kidney transplant is usually 5 to 10 days if there are no complications. The length of stay depends on medical condition and needs. A kidney from a living donor may start to make urine right away. Urine production in a cadaver kidney may take longer. The patient may need to continue dialysis until urine output is normal. Post-operatively, a patient should be monitored closely. Urine output should be measured hourly and recorded. For the first 12 to 24 hours, IV fluid replacement is based on hourly urine output. Daily labs consist of hematocrit, BUN, serum creatinine, urinalysis for blood and specific gravity. The indwelling catheter will remain in the bladder for 3 to 5 days to allow for the anastomosis healing. Urine is pink or bloody initially, but gradually returns to normal within several days to weeks. Notify physician if gross hematuria and clots are noted in the urine. The need for the catheter is closely monitored and removed ASAP to prevent infection, as it is the primary cause of death in the first year post-transplantation. A 3-way indwelling catheter is used for bladder irrigation in the presence of blood clots. Catheters are only irrigated with a physician's order. Post-operatively, the patient must keep the surgical area clean and dry until healing occurs. They also must avoid any activation or position that causes pressure to be placed on the new kidney. Other activity restrictions may apply, such as contact sports. Intake and output should be monitored, and it is important to take all medications as prescribed. Because of immunosuppression, the patient should avoid exposure to risk of infection. Knowing the signs of rejection and when to contact the care provider is of utmost importance. Follow-up care should always be a priority, as problems may be reversible if treated quick enough. There are 3 types of kidney transplant rejection. Hyperacute rejection occurs a few minutes after the transplant when the antigens are completely unmatched. It usually cannot be treated and results in the loss of the kidney. A cross-match of blood is completed before kidney transplant to identify antibodies that could cause hyperacute rejection. Acute rejection may occur any time from the first week after the transplant to 2 afterward. Acute rejection is a common complication in renal transplantation and associated with reduced graft survival. It can occur less than 3 months, as in early acute rejection, or after 3 months of the transplant, as in late acute rejection. All recipients have some amount of acute rejection. Chronic rejection can take place over many years. The body's constant immune response against the new organ slowly damages the transplanted tissues or organ. Signs and symptoms are listed on the slide and often include fever, fatigue, graft tenderness, fluid retention. Basically, many of the present with the original kidney failure. In most cases of rejection, it does not mean the new kidney is not working or will be completely rejected. Changing the amount of immunosuppressant medicine can usually treat this problem. This is why it is important for transplant patients to take immunosuppressant medicine exactly as prescribed. There are other signs of rejection that can only be detected by routine blood testing. This is why labs are drawn during follow-up appointments and hospitalizations. In addition, a kidney biopsy is almost always necessary to determine if rejection is actually occurring. Treatment of rejection usually requires a few days of hospitalization, allowing us to administer alternative immunosuppressants and observe your progress. In 1953, the first temporary successful transplant of a human kidney was performed by Jean Hamburger in Paris. A 16-year-old boy received the kidney of his mother as a living donor transplantation. In 1954, a milestone was made with the first long-term successful kidney transplantation by Joseph Murray. The transplant was done between identical twins. The organs survived for 8 years. In 1962, the kidney transplantation between genetically non-related patients was done using immunosuppression. There are 58 local donor service areas and 11 regions that are used for U.S. organ allocation. Heart and lungs have less time to be transplanted, so we use a radius from the donor hospital instead of regions when allocating those organs. Organ size is critical to a successful transplant, which means that the children often respond better to a child-sized organs. Blood type and other medical factors weigh into the allocation of every donated organ, but other factors are unique to each organ type. For kidneys, the factors include amount of time waiting on a kidney, donor-recipient immune system incompatibility, whether it is a pediatric doctor will go to a pediatric patient. Also, if the patient has had a prior living donor transplant, how far the recipient hospital is located from the donor hospital, and the recipient's benefit of survival since 2015. United Network for Organ Sharing UNOS is a private nonprofit organization that manages the nation's organ transplant system under contract with the federal government. UNOS is involved in many aspects of the organ transplant and donation process, including managing the national transplant waiting list, matching donors to recipients 24 hours a day, 365 days a year, maintaining the database that contains all organ transplant data for every transplant event that occurs in the United States, bringing together the transplant community to develop policies that make best use of the limited supply of organs and give all patients a fair chance at receiving the organ they need. Monitoring every organ match to ensure organ allocation policies are followed. Providing assistance to patients, family members, and friends. Educating transplant professionals about their important role in the donation and transplant processes, and also educating the public about the importance of organ donation. Despite efforts over the past 2 decades to increase the number of Black and Hispanic patients receiving kidney transplants from related or unrelated living donors, these racial ethnic minority patients are still much less likely to undergo such transplants than white patients, Johns Hopkins researchers report. In fact, the investigators say the disparities have worsened in the last 20 years. The findings, published in January 2 in the Journal of the American Medical Association, are based on a study of 453,162 adult first-time kidney transplant candidates nationwide. Overall, the incidence of live donor kidney transplantation increased from 1995 to 2014 among white patients, from 7% to 11.4%, and among Asian patients from 5.1% to 5.6%. But decreased over the same time period among Black patients from 3.4% to 2.9%, and Hispanic patients from 6.8% to 5.9%. Mortality rates vary depending on the ESRD treatment. After 1 year of treatment, those on dialysis have 20 to 25% mortality rate with a 5-year survival rate of 35%. Persons who receive transplants have a 3% mortality after 5 years. The Uniform Anatomical Gift Act, UAGA, or the Act, was passed in the United States in 1968 and has since been revised in 1987 and 2006. The Act sets a regulatory framework for the donation of organs, tissues, and other human body parts in the United States. The UAGA helps to regulate body donations to science, medicine, and education. The National Organ Transplant Act, NOTA, was passed by Congress in 1984. This was done to address the nation's critical shortage of organ donation and improve the matching process. It is prohibited the buying and selling of organs and established a network to maintain a national registry for organ matching. It also requires the network be operated by a private, non-profit organization contracted by the federal government. Lastly, it established a registry of transplant recipients. According to the National Institute of Diabetes and Digestive and Kidney Diseases, the 5-year survival rate for dialysis patients is 35.8% in comparison to 5-year survival rate of 85.5% for transplant patients. Click on the above link to watch one person's experience with living donor kidney transplant. Join me for our Zoom questions and answer session.